Okay, let's get started. A warm welcome to everyone here today, attending our first members' assembly. It's 14 months since our coalition began. My name is Professor Nick White. I'm based in Thailand, where I'm speaking from now. I work at the Mahidol Oxford Tropical Medicine Research Unit, and I chair the Coalition Steering Committee. The theme of our meeting today is collectively advancing COVID-19 research in resource-limited settings 1 year on. So this should be a very good meeting, and we intend to look back briefly over the past year on our collective efforts as a coalition. Presentations from many of the coalition's working groups. These have been the important engine of the coalition's efforts over this year, and several of them have project plans in development, and we're looking forward to your feedback, your questions, and your possible participation in their plans. So we'll end with a participatory discussion on what is next for the coalition, and finally wrap up with closing remarks from our steering committee member Akhona Tshangela from the Africa CDC. So I hope during this this meeting, we can evaluate where we are, assess or reassess our original objectives, acknowledge our strengths and also our weaknesses, and discuss the challenges faced and the possible solutions and next steps for us. So before we go on, I just want to go through a few housekeeping points. Next slide, please. So first of all, this meeting is being recorded and the link will be shared. If you've got technical difficulties, we have a backup team in the NDI who will hopefully be able to help. So send an email to that email address, admin@covid19crc.org. Importantly, after the assembly, we'll send you a short survey asking how we did, what the meeting was like, but also giving you an opportunity to comment, because there are many people in the meeting today, so not everyone is going to get a chance to say what they think or ask questions. So if you missed that opportunity, you'll have another one, and we'll definitely pay attention to your input. So give us feedback, and also for those of you on Twitter, do tweet about the coalition and this assembly. So the next, there's a bit more housekeeping. So this is Teams, and many of you will be familiar, but some won't. There are various options on communication. So during the Q&A sessions, you can raise your hand, the little hand next to the smiley face at the top row, which would to indicate that you'd like to speak, and then unmute yourself and ideally turn on the camera. And then when you finish, please reverse all that, if that's it, of course, if you're called. Because we've got so many people on, we're going to use something called Slido for questions, and more of that in a minute. If we do run out of time in the Q&A sessions, then you've got that opportunity to comment later on, and as I say, we'll post that link. Now, Slido. I hope you've had the opportunity to download that as a result of your information provided beforehand. But if not, here's how it works. So if you've got a mobile, which is probably the easiest option, you just scan that in, and it gets you there straight away. Somebody's got their mic. Could you mute the mics? Thanks a lot. If you're on a laptop or a desktop, then you just go to slido.com, and if you insert that code #CRC, it gets you straight in to the Slido session. And Slido is how you can ask questions and make responses at the end in the Q&A session at the end. I hope it works. I'm sure it won't work for everybody, but let's hope it does work for most of you. So we're going to have a little trial now just to check that it works out. So here is, in one word, what's your biggest challenge as a researcher? Now, if you could send in immediately whatever comes to your mind on Slido, and we'll see if it works. So please go ahead. Well, time is definitely in the lead, but money, which is time, is catching up. Yeah, more money. We'll just give it a few more seconds. That's brilliant. Well, it does work for some of you. That's good. And I hope if you haven't figured it out now, you've got a few more moments during the meeting to try and get there. But that's great. So thanks very much for that. We've got the next slide, please. So just to go back again, we started precisely 14 months ago, officially anyway, on the 2nd of April, with the publication of this commentary in the Lancet. And it was the aim of the 77 scientists, physicians, funders and policymakers who co-authored this commentary to accelerate COVID-19 clinical research in low resource settings. Now, it wasn't by directly conducting the research, we're not a funder, but by identifying the gaps and catalyzing research partnerships to answer priority research questions, to facilitate. So the coalition, why did we start? Well, we were worried that the peoples and the health systems in low resource settings were not being adequately addressed or prioritized in the global response to the pandemic. And we're very worried that the impact of COVID-19 on fragile health systems would threaten all the many hard-won gains of the last 20 years in global health. And we could see that already at that time, there was an impressive quantity of research being conducted around the world, almost 600 trials already registered at that time. But most of those trials were being planned in well-resourced settings, and most were small and they weren't adequately powered to answer urgent questions definitively. So today there are more than 8,500 clinical studies registered, and many more studies are underway in low resource settings as well, but still, unfortunately, most are conducted in or are directed towards the needs of the world's wealthier countries. And this is something that we would like to address. Next slide, please. So the idea of our coalition is that we work together to leverage each other's expertise for high impact COVID-19 research in low resource settings. We promote open sharing of research knowledge and data, and we champion and advocate for equitable and affordable access to COVID-19 vaccines, diagnostics and treatments, although we don't have many of those. So from the 77 signatories to the Lancet commentary that launched this coalition, we've expanded now to 224 institutional members, more than 400 representatives from 65 countries, and we also have nearly 300 individual members from 75 countries whose institutions have not yet joined the coalition. So you will hear more from our next speaker, Helen Rees, about the coalition's working groups and outputs over the last year, but here's a little bit of information in the next slide.
1 minute.
Showing you that 40, oh, by the way, that voice, that mysterious ghostly voice is Layla. And for all speakers, she will give you a 1 minute warning. I've just had mine. So these pie charts show you that about 40% is another quarter from research or health institutes or networks, another quarter from the non-profit sector. 35% of the membership comes from Africa, and we've been happy to see increases in the membership from Asia and Latin America as well, and about 3/4 overall of our memberships from low or middle income countries. Next, quickly, otherwise I'll get into trouble. That's our global map. So any of you have friends in Madagascar or Ireland or Mongolia, do encourage them. We'd like to fill that up. Next, please. So now I would like to ask our steering committee to switch on their cameras so you can, for proof of life. So this is our 11 12-person steering committee, which I chair, and I hope you can see some of them who've managed to switch on their cameras. And we're now going to show the engine of our coalition. It's a wonderful engine. It's our secretariat, and I'm going to please switch off now the steering committee members and switch on the cameras for the steering for our secretariat. It's a small secretariat housed by DNDi, but located across the world, and they provide us the support for the coalition. And finally, next slide, please. These are the questions that we'd like you to answer later on. 2 of them on Slido and 1 by the raise hand function. The Slido, so there'll just be 1-word answers to what, given the strengths and achievements of the coalition shared today, what do you think we should be doing more of, and what should we be doing less of? And finally, which will be a more open question, therefore, through spoken word or comments, if you don't get chosen, what should we as a coalition be aiming to achieve? So we'll see those again later. And now it's my great pleasure to introduce Professor Helen Rees. She's the Executive Director of the Wits Reproductive Health and HIV Institute at the University of Witwatersrand, where she's also an ad hominem Professor of Obstetrics and Gynecology and co-director of the Wits African Leadership in Vaccinology Excellence Flagship Programme. She's a member of our steering committee, and she's going to speak to us now about the coalition at the 1-year mark. Over to you, Helen.
Thank you very much. Good morning, good afternoon, good evening, whatever time you are in, whatever time zone. I'm delighted to be able to give this talk, and but very honoured to be part of this steering committee for what I think is going to grow as a coalition, and hopefully even would grow beyond COVID-19. So I'm going to do a review of the coalition 1 year on. Next slide, please. This is a repeat of the slide that Nick just showed you. And you can see here what we aim to do when this was started. Overall, a global research response to COVID-19 driven by the needs of low resource settings. And if you look at the top 3 boxes, we wanted to leverage global expertise for high impact COVID-19 research, promote the idea of open sharing of research knowledge and data, and champion equitable and affordable access to COVID-19 vaccines, diagnostics and treatments. I think it's worth just repeating that for those of you who are new to the thinking of the coalition. And perhaps I will just say that it doesn't matter if you're new, you've never heard of this before, this is the first time you're interacting. We're welcoming everybody, both organizations and individuals. I'm going to focus particularly though on the middle box below, which is the 13 topic specific working and advisory groups. Next slide, please. So the coalition does a lot of its work through working groups and expert advisory support groups. And in the blue are the 10 expert working groups. And I'll read them out because I think it's worth people having a look and see whether these are areas of interest, or when you give your feedback if you think we're missing anything. So clinical epidemiology, clinical management, clinical pharmacology, data management, data sharing, ethics, maternal, newborn and child health, social sciences, supply and market dynamics, looking particularly at medicine quality, virology, immunology and diagnostics. There are 3 expert advisory or cross-cutting support groups which look at regulatory, study design and analytics, and vaccines. So that is how at the moment the coalition is really trying to focus in different areas of priority. Next slide. So what are the strengths a year on of this working group structure? First of all, they are cross-functional and they have complementary expertise on each of those working groups. They also have complementary and widespread geographical representation from all the regions, which helps to give us a global perspective. It is a platform to share experiences, but also to foster new partnerships and linking to existing networks and to discuss strategies and solutions. So these are very much doing groups, looking at problems and trying to come up with recommendations. In the case of 2 of the working groups, they've been able to attract resources and funding for projects. And also, this structure does allow for a quick response to calls for projects, the experts and the I think we might need to mute somebody somewhere. Thank you. Next slide, please. So how has this worked? Because a year on, it's a good time to reflect and to see what's the strengths and what are the weaknesses of this approach. So if we look first at the challenges, I think that there's a comment here that the expertise that resides within the working group has possibly not been utilized sufficiently from researchers in LMICs. And that might be because people don't realize they can sort of say, listen, I have a protocol, I have a plan, can I look for help? And I think that that's why it's important people understand this structure, that it's there to support researchers in lower resource settings. This pool of experts can answer queries, can look at protocols and analysis plans and give that type of research. And we would encourage people to do that. Secondly, of course, time challenges, and the time challenges take many forms. One is time zones, because we're from many different parts of the world, and all of us, I think, on these working groups have competing priorities. People have been very busy, as we all know, for the last 18 months. And we have cross-functional experts, which means that very often people are so busy they can only participate in one working group, and that makes it difficult if you're trying to get cross-fertilization. I think one of the reasons for emphasizing this in this review is the visibility overall and the working groups. And we would very much like to hear from the members who are on this call and the non-members as well. How can we increase our visibility? We want to maintain participation of the members. How do we do this? With virtual interaction. Cohesion is sometimes difficult because as you see, we have many hundreds of members now. And then finding the resources and the financing, because as you see, as is coming out in the earliest question that Nick asked, financing is a real issue to do this sort of research. So what are the solutions? Well, first of all, we would want to increase the visibility of the coalition by participating in international forums, using listservs, and greater clarity of what we're doing on websites and on other websites, linked websites. We'd like to see wider dissemination of working group resources and outputs, and have a tool repository on the website that people can access, and greater collaboration across the working groups. Next slide. In terms of the next steps, these are some of the things that we've thought of, and it'll be added to by the dialogue today. Better support to researchers in low middle income countries, in the way that I've just said, support to and advice for protocols, for thoughts, for ideas. We need to be able to offer that research and link people to the correct expertise. We need to publish, because that is how we will make this concern about lack of research in low resource settings really very visible. We need to expand the network. We want more members from more regions, and we're looking to build lasting research networks. As I say, we hope that this would go beyond COVID. We want to develop and share collaborative ideas for research and attract funding, your question as well. On common areas of research interest and across working groups, and contribute to methodological analyses. Next slide. So in terms of the coalition achievements and outputs beyond the working groups in year one, just a couple of slides on this. First of all, advocacy. This is really, really important, because we want to see the voices of researchers from the LMICs in global decision making and priority setting for research, really using the coalition to raise this. There are bodies such as the ACT Accelerator, where we should be able to not only have our voices there, but also access funding. We also want advocacy for responsible scientific communication, and we're all aware how science can be used for the good, the bad, and the muddling. And we need to make sure that across the whole of the global regions, that we've got responsible, sensible, interpreted scientific communication going on out there. Secondly, priority research questions, and you saw the working groups, but some have been prioritized in social science, maternal, newborn and child health, clinical epidemiology, and virology, immunology, and diagnostics. But there are clearly more questions that could be posed. We want to translate those into project proposals, and some of that is already underway. Next slide. Thirdly, partnerships. This is really an opportunity, and we've already seen this starting to happen, for global networking, both within the working groups, but also outside it. We're looking for external collaboration opportunities with other entities, other global entities, so that we start to become a LinkedIn network across others who are thinking along the same lines. And we want a platform in which to highlight and discuss our work in lower resource settings. Very importantly, one of the things that's been done is focused on is capacity building, resource and skill sharing. There have been online workshops, data sharing courses, and tools and information put onto the website. But so capacity building we see as extremely important, and be interesting to hear from people what your priority is on this. Then evidence generation and evaluation. There's been a live systematic review looking at clinical research gaps, but clearly systematic reviews at the moment are some of the most important tools that we have to sort out and interpret the stronger research from the weaker research, and particularly as it applies to LMICs. And then surveys. There have been surveys that have been completed and are planned, for example, challenges in accessing and using data, and data management tools that are in use. So surveys are very important to tell us what's going on out there, and more will be done in the next year. Next slide. The last slide on our achievements looks at the webinars. We've had 8 webinars on a range of topics. For example, the challenges of conducting research in LMIC settings, which I think we're all acutely aware of, and it goes beyond finance. Community engagement in vaccine trials, and in fact in other trials as well. Trial protocol relevance for LMICs. Very often the master protocol, for example, sits and was developed for northern, well-resourced countries. How do we make relevance for our settings? And then webinars on COVID-19 diagnostics, on research ethics, and so on. And we hope to have more of these webinars in the future year. There have been a number of articles published, but we want to publish, because by publishing, we are going to raise the voices of researchers from lower resource settings. Here are some of the papers that have been published. There's in Lancet Digital Health, Solutions to COVID-19 Data Sharing. In the Lancet, guidelines should not pool evidence from uncomplicated and severe COVID-19. And then from the recently submitted manuscript has looked at data sharing, maternal child health, and others from the other working groups that you saw, virology, immunology, and diagnostic, clinical pharmacology. So we see this as a very important way to get messages out there. And then funded projects, and we want to give our appreciation to WHO. We've had funding for ethics work, the working group, for 2 projects, but we've also had funding for data sharing working group for 4 projects. So these are some of the achievements in year 1, but we really want to push the profile and the participation in the coalition up into year 2. And so I'm going to now hand over to the next speaker, who is going to moderate the next session, and will give you more information on the working groups and some of the focus areas that we've looked at. That's Dr. Nathalie Strub-Wourgaft, who is a steering committee member, and she's based in Geneva and associated with the DNDi. And Nathalie will take the next session. Thank you very much.
Thank you very much, Helen, and I'm really thrilled to moderate this session, which is going to really look into the details of what this coalition and 4 of the working groups have achieved and have identified as very key priority research questions for LMICs. So we will hear from clinical epidemiology, from social science, from data sharing, and from maternal, newborn, and child health. And I think when you listen to those talks, maybe you can think of, again, the questions that were asked, but also about what was seen as being the strength of these working groups and how they could even better collaborate and share some projects, because there might be, as you will see, some transversal issues, and we could come with some solid responses that we are all looking for. So just housekeeping, as you may remember, so for questions, kindly use Slido. We will have 5 minutes questions after 10 minutes presentation, and Laila will help us to keep time to be fair on everyone. And if you have a comment to make, kindly use the chat and the hand, and I will try to make sure to be fair on addressing this. So without further delay, it's now my pleasure to introduce Professor Juan Carlos Villar, Clinical Epidemiology Working Group Co-Chair and Professor of Medicine at Universidad Autónoma de Bucaramanga. He's also head of the Research Center at Fundación Cardioinfantil Instituto de Cardiología in Bogota. He will speak to us about the Clinical Epidemiology Working Group and a research project that they are developing. Over to you, Juan Carlos.
Thank you very, very much, Nathalie, and good to see you again. I saw you last time, Adventures in Cheah, as this is somewhere.
Well repurposed, yeah.
Can I take the control of the slides, please?
Yes, I think
that
you
to me
can.
would be great.
Damien, is it okay?
No. Okay. Okay. Next slide, please. Thank you. Hello to everyone again, and thank you very, very much for the steering committee for this great job that they have presented. I feel honored and speaking on behalf of this working group of clinical epidemiology. We are altogether 15 members from different regions. From Latin America, we have 6 colleagues, 2 from the USA, 3 from different countries in Africa, 2 from Europe, and 2 from Asia. One of them have recently joined. And we have been hosting bi-weekly meetings, so every 2 weeks. From July 2020, we have done 20 meetings already. And basically, we have gone through this type of activities. We started meeting each other. Then we embarked in an exercise of prioritization of research questions. We hosted a webinar on a basic overview of the challenges in conducting clinical research and the particularities of conducting clinical research in resource-limited settings. We collected some statements from different members of the group, so we have an overview of what was happening in research in the countries where we are from. And we started more recently to do sharing sessions, showing the group of different members and trying to inspire each other on different possibilities. We submitted a paper for publication on the exercise of prioritization. I didn't see it in the list that Dr. C presented. It's being actually resubmitted. We'll see. And we have a second webinar in preparation for the topic of evidence synthesis, which is very important, as you heard. We are working in a second paper and a more qualitative synthesis of what is happening in our countries, and we will continue doing sessions showing our own work and trying to get commonalities from each other. Next slide, please. This is the first output of the group, showing 6 prioritized questions out of, we have actually 2 rounds of work doing a Delphi type of approach, and we ended up with 6 of these questions. So we, as time happens, time goes on, priorities may change, and we redid this exercise. And next slide, please. We scored the questions again within the group with the lowest scores, meaning this is the first priority for the rater. So we have, as you can see, the first one and the last one as clearly prioritized questions out of the 6 that we already prioritized. So next slide, please. We ended up with these 2. What clinical findings, either signs, symptoms, biomarkers, or imaging, were associated with worse prognosis in COVID-19? And on the other hand, what are the short and mid and long-term post-infectious sequelae in COVID-19? And we saw the opportunity to mix them together. Next slide, please, and make as one final research question that we think it's the one arrow that we want to throw as a research question, which is what are the clinical findings that are associated with the worst prognosis and sequela, post-infectious sequela in COVID-19. Next slide, please. With this question, what we think as approach is to try to work in setting up either a standalone cohort, either retrospective or prospective, including patients for different continents in the South, in the so-called Global South, or to work together within a clinical trial and to nest a cohort study within that clinical trial. We see that by doing that, we can facilitate implementation and organization of clinical care, standardization of clinical care, getting up to the clinical care for our communities. It will also make easier the process of knowledge translation in our low and middle income countries context. And definitely that will strengthen South-South collaboration that is much needed and that is also in the focus of the coalition. And obviously, it will facilitate research, either multi-centric or international research, collaborative research, or local research on therapies and or social implications of long COVID in these our countries. Next slide, please. So this is the final slide, and we see that under the umbrella of the coalition, we can either start participating in an ongoing registry, one of those that are already going on, such as ISARIC, the WHO Long COVID Global Platform, and or clinical trials such as anti-COVID trial that is being run in Africa. We can take part of that, join that, enhance that, and work through that those initiatives. And also we envision to support also social sciences and implementation research by working in topics such as vaccine acceptance, attitudes, preference from communities, to study what happens with things such as prescriptions. For example, the anti-malaria prescriptions for COVID-19 in Africa, clinical practice patterns, adherence to recommendations, evidence-based recommendations that we had. Anyway, by having that as a first step, we envision to assemble an international prospective clinical study that is large enough, that has at least 10,000 patients that are followed for at least a couple of years with different coordination sites in every continent, performing different measurements and integrating several strengths from research centers at lower and middle income countries. This is such an unprecedented enterprise that is still missing, and that we see that as a very important opportunity, and especially to set it up to think of working even beyond this pandemic in doing South-South collaboration in clinical research. This is our message for today, and we thank you for your attention. And if I'm ready for questions, if you have it. Thank you.
Very good. So you do have a question about why are some countries more affected than others, and it might be a research question rather than asking you directly to respond. What do you think about this question? On
one hand, we did have a sort of similar question in the list of the questions, the research questions that we prioritized at the beginning. We had a question on, I remember two questions that are slightly related. One on the excess of non-COVID mortality during the pandemic, and the other was one in the adherence for treatments for non-communicable diseases during the pandemic. I personally think that the more developed in general the country and the society is, and the more developed and flexible and adaptive to change the healthcare system, the better outcomes you have. And I would personally, I'm maybe a little biased to that, but I think a definitely variable influencing that worst outcomes is the capacity to handle non-communicable diseases during the pandemic.
Thank you very much, Juan Carlos. Do we have other questions? Yes, we have someone who would like to make a comment. Robert Cole-Bunders, please.
Yes, thank you very much, Carlos. It's very important to have cohorts of low and middle income countries. You may know there are big initiatives at European level where they also put all together big cohorts. I'm personally part of one of the applications now for doing so and analyzing that, including looking at biomarkers and omics. But I think what is very special in low and middle income countries that has not been looked at very well, that is the influence of parasites. For example, malaria and other helminths, neglected diseases, because that is really different, and that may explain some of the differences in evolution of the disease that has not, in my mind, not been explored, and I would be very interested to collaborate on such an initiative.
Yeah,
can I maybe, Juan Carlos, ask you, because we have two other members who are asking how to collaborate. So I'm just trying to link with the comment that was made. How can we collaborate in your projects?
Well, we have for now the platform of the working group itself, and what anyone can do, and people our colleagues are very welcome to do it, is to contact us. The information is in the website of the coalition, or under the Clinical Epidemiology Working Group, to contact us to join or to just exchange an idea on how to collaborate in one of the projects. And the first step is definitely to contact us, and the information is under the Clinical Epidemiology Working Group within the webpage of the coalition.
1 minute.
Thank you. Maybe I can add a point that you will receive a form after the meeting where you can express your interest in collaborating to some of the projects. So that will be a way of responding.
Yeah, absolutely.
Yeah. So there's another question here. Is there research proposed on MISA, adult onset, PMISTS within this research?
I'm not sure. I understand the acronyms, the PMS, TS, MAS.
Yeah. Lauren, would you like to give us more detail? I think I'm not sure I know the acronym well. I don't want to misspell them.
Yeah, no, I'm sorry. I don't get
up.
exactly the second one. If someone can explain it to me.
So we'll ask Lauren to write a little bit more in the in Slido, and then we have a question on the registry in Africa. Is there a registry that will provide information on COVID-19 researches in the continent? I don't know if you or someone else from your group would like to respond to this.
Yeah, if we have colleagues from Africa, but in the meantime, we are not aware of a registry that is large and varied enough in Africa, but we have lots of hope that the anti-COVID trial will set some capacity to collect data in a collaborative and multi-center way to start having baseline information of variations on clinical characteristics and especially clinical care of patients across African countries.
Time is up.
Time is up. Okay, well, we have more questions for you, Juan Carlos. It's already quite a dynamic session, so we'll have to stop. I'm sorry, but there will be more. Thank you so much.
Thank you. Thank you so much.
We'll now move to the next session, which is the Social Science Working Group, with a presentation by the two working group co-chairs, Dr. David Kaawa-Mafigiri, who's a senior lecturer in the Department of Social Work and Social Administration, School of Social Sciences, Makerere University in Kampala, and Professor Shelley Lees, who's a medical anthropologist at the London School of Hygiene and Tropical Medicine. Over to you.
Thank you. Can you hear me okay?
Very well.
Great, thank you. We're going to do the presentation between us. So if we go to the next slide. Just very quickly to give you a summary of what our working group has been doing less than a year really. We've managed to set up a robust membership from all geographic areas, although we're still looking to include people from other regions. So if there is any interest in that. We have bi-weekly meetings and regularly have discussions and working documents offline. We have a webinar series, and so far we have done 2 webinars, one on vaccine development, so looking at lessons learned from social science and community engagement in clinical trials in the Global South, and then operational experience in vaccine trials, where we were able to include colleagues who have on-the-ground experiences of working in clinical trials and engaging with communities. And we have a further webinar planned, and we're also working on written commentaries on social science and COVID-19 and policy and practice. Next slide. So drawing on our expertise as a working group and our connections to other social science collaborations and colleagues across both the Global North and the Global South, we have discussed potentially 3 projects, although I think some of these may overlap, and I'm really pleased to potentially have a discussion with the clinical epidemiology working group about the ways in which we can work in a multidisciplinary way. Our first project idea is really drawn on our own expertise in conducting social science during particularly Ebola vaccine trials, but other vaccine trials, as well as One Health vaccine trials in the Global South, and also anthropological and social science research around vaccine deployment during epidemics. And we feel that there is an important need to understand the complexity around vaccine deployment in the Global South. We have this situation at the moment where we are seeing growing vaccine inequity globally, but at the same time, we see vaccine hesitancy. And so I think we think it would be really, really important to explore in many of the contexts that we're working in sub-Saharan Africa, Bangladesh and elsewhere, the ways in which local people will understand both vaccine inequity, vaccine scarcity, and how that might impact on their own vaccine hesitancy, or perhaps in ways in which challenging vaccine inequity can increase vaccine confidence in these contexts. So our approach to, well, our 4 areas for the working group are really around political economy. So looking at political, historical and social contexts around COVID-19, transnationalism and preventative and health-seeking behaviour. And we think that all of those areas need to be incorporated in any understanding of vaccine hesitancy. This would be a really important piece of work as multi-sited, and David will talk a bit more about that. The other area we think that might be important, and well, perhaps will become more and more important to explore, is the impact of long COVID on individuals and healthcare systems. We understand in many of the contexts that we work that there's very little research being conducted on long COVID, although we are starting to hear from our colleagues on the ground about people experiencing long COVID symptoms. And so again, perhaps this could be something alongside a clinical and other working groups, the need to understand the impact of long COVID on individuals, on their everyday lives, and healthcare systems and LMICs. And this draws on from a lot of our work on HIV and the long impact of HIV on people's lives.
1 minute.
Fine, sorry. And then finally, just to reiterate what the clinical working group was saying, that we could do a mixed methods approach. Hand over to David. Sorry, David. Next slide.
Thank you, Shelley. And I think we think of this slide, the only slide I'll present, as a way forward, if you will, on approaches we may use to realize those projects, that areas that Shelley has mentioned. So first of all, we think that this kind of work is multi-year, as opposed to what is currently quite common, which is a very short-term, quick insight into an area. So multi-year projects with different sites, so that we can compare different contexts. The sites could be countries or could be within countries themselves. In some of our local contexts, there's such variability between geographical areas or cultural ethnic groups and the like. Secondly, we think we know of certain factors we've identified that are quite important, and we need to figure out these as a working group. I'm calling these enablers here. So funding for field work. This kind of work will require funding. So we need to think of it the way we think of the, say, the clinical work, the vaccines, the biomedical aspects. A lot of funding, and then research teams. We are fortunate. We are fortunate that we have a lot of teams put together. So going forward, I think it's not a very big problem. So our time is up, but I will leave that slide showing just the details of what we can do going forward, and for you to probably pose some questions. Thank you. Over.
Thank you very much. It's over to thank you, because it's again terribly accurate and needed. So a question immediately for you: is health system response a proper topic for this working group?
Yes. I mean, that's an interesting question. I mean, essentially, as social scientists, we will look at perhaps trust in health services, the experiences of health service workers. So we will look at the social aspects of health systems. I hope. Yeah.
I think you've answered. Thank you. Are there someone who would like to make a comment and speak, or questions on slide 2? What we can say already is that there is a connection with the previous session, clearly. And how would you see, what did you have in mind in terms of the the social impact, because it's quite huge, and what were you specifically thinking about? And would it be different if we do it in the frame of a clinical study or a cohort? Any preference, any change?
Yeah, our working group has quite a lot of experience working alongside clinical studies, and we might follow the lives of many of the participants in the cohort follow their everyday lives. We could even work in the communities around the cohort, sort of trace stories of how people have become infected, how they're managing perhaps with long COVID. So we have quite a lot of experience of integrating social science into clinical research by conducting very, very specific specific social science questions that might overlap with the clinical questions, but at the same time contextualize more the political, economic, social context of people's experiences. So without going into detail, we do have a lot of experiences of integrating into clinical research.
Well, thank you very much. So there are a lot of questions. One, I think, which is about the stage of the vaccine hesitancy project, if you could respond. I think you responded to the political impacts of COVID on societies, if you want to address this one, if not. And then if we know if there are much data on long COVID in the different regions, low and middle income countries. I'll stop here because there are more, if you can answer these 3 questions.
I mean, there's a lot of work across globally on vaccine hesitancy, but our proposal is really to look at the sort of conflict between vaccine hesitancy and vaccine inequities. David, I don't know if you want to answer any of these questions. Sorry, I'm just very conscious of time.
Yeah, thank you. I think you we don't have a lot of time, but yes, these are very interesting questions.
Mm-hmm.
Data on long COVID, I saw something about data on long COVID. I don't know that there is a lot of data because, first of all, we are not yet so far into long COVID, but that is why we need this kind of studies now. That's why this kind of partnership is important. So alongside clinical trials, this is a good element to study. We know from our studies in Ebola, for example, Ebola survivors, that down the road there are so many side effects, both on their physiology or even in their social lives. So long COVID, yes, we still need to study all this. Over.
Thank you. I think just one more, the last question I'd like you to answer. How would social sciences research mainstream impact of pandemic on vulnerable groups like migrants, refugees, and people in prison-like situation?
This is an excellent question. I mean, one of our key areas is to look at transnationalism and the effect of COVID on migrants, and I think that's really, really important. And one of our colleagues actually is working on a project of COVID-19 in prison in Guinea. So I think on vulnerable populations, this is incredibly important. And we have a lot of research to do. We're really want to focus our questions for this discussion today, but thank you for that question.
And then maybe another one on, how you're going to address statements usually made in local language. Is it preferable in countries that the statement should be reflected in dual language? How are you going to manage this?
I don't fully understand what it means by statements, but in terms of any research we do, we always work in a local language. Not quite clear what the question means, but we should always work. We work yeah, we should
well,
always
that
work.
it could be, I think, a bias in the way you ask the question, if the, you know, if it's not perceived the same way in the language you're asking it.
Yeah.
So that's why, for
we do a lot
validation.
of work on sort of translation of meaning. And so, yeah, language is incredibly important, certainly in terms of we use anthropologists who work locally in local languages.
So then you have time. Oh, okay, so very again. So note that the questions that have not been answered will be shared, and we'll try to make sure that you do get an answer. And any suggestion will also be shared, of course, with the working group. And you can always fill the form at the end to bring further contribution. So thank you again for this really interesting working group feedback. We will now move, sorry for this, but we need now to move to the data sharing working group, a very important topic, even mentioned by Dr. Tedros at the closer of the World Health Assembly. So we will have Professor Yeong Cheah, who is chair of the data sharing working group and associate professor at Oxford University, as well as head of bioethics and engagement at the Bangkok-based Mahidol Oxford Tropical Medicine Research Unit, presenting on this very important topic. Over to you, Yeong.
Hello, thank you. Can you hear me? Just to check.
Very well.
All right, thank you very much. So thank you very much, Nathalie. Hi, I'm Yeong Cheah, a bioethicist at Moro and based in Thailand. And I'm also an associate professor at the University of Oxford. Next slide, please. So I'm presenting on behalf of the data sharing working group. Our overarching aim is to facilitate and promote effective, ethical, and equitable data sharing across geographies and disciplines. We hope to promote the greatest use possible of the data generated to help with the management of the pandemic, while protecting the interests of study participants, their communities, and researchers who generated the data. There has been a greater call by funders and journals for greater sharing of de-identified individual level health.
Yeong,
Is the sound good?
sorry,
for everyone?
you're
Yes.
on mute now.
Yeah,
Oh,
we cannot hear you. Yeah.
Okay, I'm unmute. Okay, I think I'm okay now, right?
Right.
Yes, we can hear you.
All right. Next slide, please. So what have we been up to? We very luckily, as a working group, we obtained funding from WHO at the end of last year to conduct these projects. We got about $100,000. First was to map out the current practices on data sharing, and this is through literature review. Second, to map compliance to data sharing policies by authors and journals. We can say that the compliance is relatively low. Thirdly, to characterize data sharing requirements and practices across trial registries. Our ultimate aim was to identify the gaps and then make recommendations to harmonize these policies across trial registries. The next one was to assess the needs of researchers to share and use data, and this was through an online workshop we ran last year. We think that one of the main reasons for the lack of sharing is because researchers do not know how to share data. For example, what repositories to use, what wording to put in the information sheet. So training on data sharing is necessary. The next one is to understand concerns around broad consent for future use. This is a project conducted in Colombia. This project involved a series of qualitative interviews with ethics committee members. One of the concerns identified is that the information related to data sharing is not clear from participants. This confirms finding reported by other researchers. May I have the next slide, please? This project was started prior to COVID, in fact, but we refined the modules with the working group. Sorry, this is slide 4, isn't it? This project also was conceived before COVID and benefited from the input and support from the working group members. It focuses on reusing data collected by others and focusing on these 4 things: findability, accessibility, interoperability, and reusability, or the FAIR principles. We want to understand if and how shared clinical data is used and what challenges are experienced with accessing and using the data. Next slide, please. This project was also started prior to COVID, but we refined the modules with the working group and got additional funding for it as a working group. This course is aimed at early career researchers, postgraduate students, and clinical research support staff who are collecting, managing, and using health data. It's not really designed to train data managers or statisticians, although they might be useful. So we launched 3 modules since December 2020. They were written and peer-reviewed by members of the working group. They are free and you can even download a certificate. So looking at the modules, the Data Governance Policies and Data Access Committee module, this is about how to write a data sharing policy for your institution and various data access mechanisms. Data quality, self-explanatory. Introduction to data management covers basic concepts of data management. Please look at the figures in red. I think they're pretty impressive. Take the last row, for instance, Introduction to Data Management, written by Brian Mutinda. This has been taken 3,661 times since its launch by 1,965 users, and 1,200 certificates has been awarded. Next slide, please. So what are we going to do next? The first thing is we'll work with the clinical pharmacology group who are planning to conduct some individual level patient data analysis. The first priority identified by them is ivermectin for early treatment. This is to say that they want to collect raw data from published studies on ivermectin for the treatment of COVID-19. So our working group will be responsible to help approach investigators to ensure that the process is ethical and equitable, to ensure that meaningful participation from primary investigators are sought, and to explore ways of increasing incentives for these primary investigators to share their data.
1 minute.
Next slide, please. So the next is to expand the survey by translating it to major languages. There's a QR code on the slide. Hint, hint, please help us by completing the survey and disseminating to your networks. Next slide, please. So it seems to me, to us, that there's a real appetite for training. We have a lot more modules identified as important, and here are the modules. We seek funding as well as authors and reviewers for these new modules. We have some already identified. Next slide, please. So this is my final slide. Many, many thanks for all the working group members and funders. We have members who are researchers working on ethics, regulatory, data management, and operational aspects of data sharing, many of whom have collected and shared data, and we have a wide range of experiences. It has been a real pleasure chairing this international group, and thank you all very much. That's all from me.
Thank you very, very much, Phaik Yeong. I think you're addressing a very central problem related to especially COVID, where without sharing, we've lost time already. So I don't know if anyone would like to either comment or address questions. I was wondering if social sciences should not be working with you to also understand if there are, other than ethics and lack of knowledge, if there are other barriers that may be linked to other factors more related to, well, background. What do you think?
That would be great. One thing that we can do is having some real understanding using qualitative methods of some of the background challenges of data sharing, not just the sharing but the reusing. So we have the technical parts and the more the other ethics part as well. And there's one module which I'm looking for an author, or we are looking for an author on, is the sharing of qualitative data. There's so much qualitative data on COVID. There's not much sharing, and that of course it is different from quantitative data because the technical bits are different. But we should figure out a way how to do it to maximize its use.
Yes, because I think I will speak as a member of the coalition, where we have asked and offered to many researchers to even share the clinical study protocols. So I'm not even talking about data, I'm talking about protocols. It's been quite difficult. We've not managed to get all of them, not speaking even about SOPs, and that was one of the ideas that we thought would help, is to share things which are non-proprietary but so useful. I don't know if your research is looking at even a higher level of sharing of documents.
That's a really good point. To be honest, we haven't actually looked at that. We are focusing on more data, but that's certainly something to look at.
Okay, so are there maybe members of the working group who are attending here who would like to compliment or make some comments? So clearly you're on a tough topic, I think. It's been also, I think, realized by many, and at a few of the global meetings at WHO, that data sharing was going to be required, because if you look at the way meta-analysis have been conducting, and due to the heterogeneity of the protocols, it's without this we'll have problems. So an interesting question from Laila: are there any barriers that are due to local laws or lack thereof? One question to you.
Indeed. So one of the things that we have to, one of the challenges to data sharing is data protection. So data protection, for example, the GDPR in the UK, very, very strict. So it pulls you in one direction, and data sharing pulls you in the other direction. One is to have data as open as possible to maximize the utility, and GDPR asks you to share as little as possible to protect confidentiality. So we really should focus on balancing the two pools. So a lot of this has to do with consent, the right consent wording and the right permissions that we need to get. So GDPR is EU specific. GDPR stands for Data Protection Regulations or something like that. And in Thailand, where I'm based, there will be an equivalent coming up. And many of the countries in LMICs will have their own as well. I know Malaysia has one. Thailand will certainly have one in the next few months. So yes, there are local regulations, and local ethics committee have their own guidelines as well. So we got to look at that, and they're not always the same.
Thank you, and I think okay, there's another. Okay, we had that question. It was a question from Kathmandu, in fact, from Nepal. And then maybe you mentioned this IPD analysis on ivermectin. So clearly a lot of studies done on ivermectin. Are you going to go back to patient consent? How are you going to manage this? This is a tricky one, because they all can finish those studies. Yeah.
That's a great question. So I'm still waiting for more information from the clinical pharmacology working group. Once we have identified which data sets we would like to have, and then we need to look at the data sets really carefully, how they were collected, and scrutinize the consent documents to see whether permission has been sought prior to these patients entering the study. So we'll need broad consent for reusing the data before we can use it, unless it's mandated by the law of that country that information can be shared.
Thank you. And when you've done this, I think sharing how you obtained a way to share would be a great publication. Will help a lot. So I don't know if how much time we have, if anyone would like to bring another comment or question on this.
You have 1 minute left, Nathalie.
1 minute. Still time. Please don't be shy. Thank you, Patty. how could data sharing could also promote, strengthen local capacities in research? Because people in LMIC feel usually that by just sharing data, they don't get any benefits locally. Great question.
That's a great question. That's a great question. If you notice, our objective is not to promote data sharing as much as possible, but to promote equitable and efficient and effective sharing. So sharing, yes, but also to protect the investigators who collect the data, to protect the participants, and within the scope of the law. My suggestion would be to have a data sharing agreement in place between the data secondary users and the people who collected the data who are in LMICs, and have a capacity building arrangement as well. And it's not just one way. I think it's two ways, because investigators in the high income setting will not understand the context and won't have the experience and the cultural competencies of how the local data was collected. And if the LMIC researcher wants to learn data science or whatever it is, that they think they lack capacity in, may not be true, then you have it arranged in the negotiated in the data sharing agreement. So one thing I need to emphasize is have an agreement and to make before the data is shared, so that it's mutually beneficial and to the patients.
Yeah, and maybe you could also. Frustrating. Okay, we have to stop. Sorry, Pyongyang. Again, there are great questions there, so we'll put your questions in forms. Anyhow, we'll keep them. Thank you so much, and sorry to interrupt. We now will have the final presentation for this first session, which is from Maternal, Newborn and Child Health Working Group, with Dr. Melanie Etti, who is the coordinator of the Maternal, Newborn and Child Health Working Group and a clinical research fellow in pediatric infectious diseases and microbiology with Makerere University and Johns Hopkins University Research Collaboration and the Institute for Infection and Immunity, St. George's Hospital, University of London. Dr. Etti will be presenting with one of the working group's co-chairs, Dr. Kirsty Doare, who is UKRI Future Leaders Fellow and Professor of Global Health within the Pediatric Infectious Disease Research Group at St. George's University of London, based at MRC UVRI at LSTMH. In Uganda. Over to you. Thank you very much.
Thank you so much, Nathalie. It's all of those acronyms were a real mouthful, so thank you very much for being with us. I'll just see if I can request control for the slides, but actually we only have 5 slides, so perhaps Damian, if I'll just ask you to go to the next slide. So my name is Melanie and I'm the working group coordinator. I just thought I'd start by talking about our working group composition. We're very fortunate in that we have a number of specialties encompassed within our working group. So not only obstetricians and gynecologists and pediatricians, but also specialists in a background of sexual and reproductive health, infectious diseases, and also bioethics. And even within our pediatric specialists, we have a number of subspecialists in neonatology and pediatric infectious diseases. And I feel that that really helps to add to the richness of our group. We're also fortunate in that we have specialists from a number of locations internationally, from Africa, Asia, Europe, Central and South America, North America, and we're still looking to widen our working group and invite participants from all corners of the world, really. Next slide, please, Damian. So I just thought I'd talk a little bit about our research priority setting exercise that we conducted at the end of last year. So similar to the epidemiology group, we disseminated a questionnaire using a Delphi-like method, or Delphi-like approach, I should say. We had two rounds of questionnaires sent out. The first questionnaire received 225 responses from respondents from 29 countries around the world. And we refined the responses from that questionnaire through our second questionnaire and identified 4 key research priority themes, which I'll talk about on the next slide. So next slide, please, Damien. So sorry, the text is a little bit small on this slide, but I just wanted to encompass or to include the themes that we had identified, as well as research questions within each of the themes that we found to be important. And I suppose an interesting thing to say is that although we disseminated the questionnaire hoping to see whether there would be key differences in different regions and across specialties, actually what we found was that there was a great degree of consensus, and that really allowed us to come up with these 4 priority research themes. So theme 1 is focusing on access to healthcare, particularly for vulnerable members of society, and particularly in low and middle income countries. So the research questions that we identified was to work out or to ask how has the COVID-19 pandemic response affected access, particularly for women and children to maternal, sexual, reproductive and child and adolescent health services. We also considered access as meaning equitable access to treatment and vaccine trials. And so one big question that we are seeking to answer is how can we ensure that pregnant and breastfeeding women gain equitable access to not only COVID-19 treatment and vaccine trials, but public health emergency trials going forward. And I think that's an important piece of work that we can take forward after the end of this current pandemic. We also, so theme 2 was looking at the direct effects of the virus on pregnant and breastfeeding women and children. And it's been fairly firmly established that COVID-19 affects pregnant women more severely than non-pregnant women. And I think now that that has been established, it's important that we try and identify the underlying pathological basis for that. We were very fortunate to be joined by a speaker from the IPOC consortium who's working to identify the reasons for these outcomes. And then also similarly, we were joined by a researcher from the Signpost study who is looking at the neurodevelopmental effects of the SARS-CoV virus on neonates who are exposed in utero. And again, we think that that's a very important question. So theme 3 was looking at the indirect. Oh, sorry, I'll speed up then. So theme 3 is looking at the indirect effects of the COVID-19 pandemic response on pregnant and breastfeeding women. And then theme 4 was focused primarily on transmission of COVID-19 and protection from infection. So looking at routes of potential routes of mother-to-child transmission. Now also looking at the role of maternally derived antibodies in protecting neonates from infection. Next slide, please. So just to summarize the activities that we've been involved with over the last year. So as mentioned in Professor Rees's presentation, so we have written a research paper based on the outcome of these questionnaires, and it's currently undergoing peer review. So we'll keep you informed of the outcome of that. Our working group also presented our research themes in a webinar which we hosted last week, and one of our members, Jacqueline Alga, has also presented these findings at a webinar hosted by Oras Konhu a couple of months ago. Within our sessions, we also hold networking sessions where we invite speakers and researchers from other international consortiums, really just to try and build relationships and build bridges. And we are also working with the ethics working group to put together an organized session for the European Congress of Tropical Medicine and International Health. And that's expected to take place at the end of September of this year. So I'll hand you over to Kirsty, our co-chair.
Thanks, Mel. Hello, everybody. Could I have the last slide, please? And now I'll be quick because I realise our time is running away. This is really about looking forward for what we would like to do with the working group over the next 12 months. We'd really like to continue to expand our membership, specifically if anybody from Asia or from Africa would like to join, that would be wonderful. We would really like to start to refine and develop these research questions so that they're not so much an academic exercise, but actually begin to think about these as questions where we could start to provide guidance for pregnant and lactating women through this pandemic. We're continuing to work with the COVAX group for maternal vaccine safety, and there's a large international maternal vaccine trial which is about to start with many of the members of our working group involved. And we would like to formalise the cohorts within the coalition to start to develop grant applications together with our colleagues in the epidemiology group and with the ethics group to start to answer some of the research questions, and then to identify research champions within the different regions to lead on these research areas so that we've got an equitable research consortium for ongoing research in maternal, neonatal, child and sexual health. Thank you very much.
Thank you very, very much. Extremely busy and interesting and important agenda questions here. I would like, okay, we have a question. So usually in LMIC, only a proportion of patients attend public health service for care. In COVID, most care is in public care setting. How you're addressing this in connection in your maternal, in your study, MNCH study.
Mel, do you want to take that one? So this is about public versus private hospitals, presumably.
Yeah.
So we actually, I think we know whether the respondents were from public or private hospitals, and actually the majority of the respondents from LMICs were from public hospitals, and so we're hoping that there was quite a wide balance. Mel's done a lot of sensitivity analyses between the different forms of care involved in answering the research questions.
Thank you. Yes, another. I think you addressed a bit this, but another question about the how the connection is being made between this group and the clinical epidemiology working group. It's a good question too.
So yes, we're very keen to work together to try and put some of these research priorities into action. So we'll be following up with the clinical epidemiology group after this meeting to try and progress that a little bit.
Thank you. Are there anyone would like to speak? Raise your hand. So you mentioned transmission, congenital transmission. Are there any data on this, or how are we going to manage that?
So Kirsty, I'll leave that to you.
So we're running a large, now 9-country study looking at transmission in pregnancy and in breastfeeding, which will recruit approximately 10,000 women across countries in sub-Saharan Africa to try and answer that question. And we're hoping that, well, the trial completes in December of this year, so we should have the data from that towards the middle of next year. I noticed in the chat there's a question about involving junior researchers from low and middle income countries in the research, and certainly from our point of view, we would love to have more early career researchers involved, and we'd be very happy for anybody that would like to be involved in this research to get in touch.
Great, and we have Soraya Torres who would like, thank you, sorry Laila, who would like to speak. Over to you.
Hi, thank you very much for your talk. It was very nice to hear. I'm very happy to participate of this group. I'm interested if you have any data on different times of the pregnancy, because we know when pregnant women are, well, carrying a baby, they are kind of more. Is it different from when they get COVID-19 from, I'm sorry, from the first month to the, I don't know, 7th or 9th month? Thank you.
So as I understand, I think the worst outcomes seen in COVID-19 in pregnancy are towards or within the 3rd trimester. I don't know if you agree, Kirsty, but certainly from whilst we don't have specific data from the systematic reviews and meta-analyses that I have read, it seems that the majority of intensive care admissions and increased disease severity tends to occur in the 3rd trimester.
Yes, I think that is also because we're still too early in the pandemic, although we're not now, to be able to really understand different trimesters. I think time will tell. But there's several studies that are looking at that specifically, because is this going to be like CMV and the virus affects organogenesis, or actually is this going to be something that you get in the final trimester that makes you sick? So I'm sorry, my brain's gone blank. I promise I'm a paediatrician in real life. But something that will make the baby sick, but actually it doesn't matter when you have it in pregnancy, but we don't know that as yet.
Thank you very much. I think we have to close again. Sorry for that. We have to close the session. It was a very rich one. We'll come maybe back to it at the very end for lessons learned and future projects. But for now, I'd like to hand, you have claps for all your presentations. So now I'd like to hand over the moderation to Professor Patricia Garcia, who was professor at the School of Public Health at Cayetano Heredia University in Lima, in Peru, and member of the US National Academy of Medicine. She's the former Minister of Health of Peru, former Dean of the School of Public Health at UPCH, and former Chief of the Peruvian National Institute of Health, and she is also a member of our steering committee. Over to you, Patty. We cannot hear you. Are you here, Patty?
Patty is here, but it looks like she can't unmute herself right now.
Ah, maybe can someone help? Damien, maybe can you help?
Yes, we will work on that. Could you maybe continue?
Sure. So we will start with the Virology, Immunology and Diagnostic Working Group thank you. And Dr. Wilber Sabiiti is going to introduce us to the key questions from that group. Over to you, Wilber.
Thank you very much for that introduction. I'm Dr. Wilber Sabiiti from the University of St. Andrews, and I'm a member of the Immunology, Virology, Diagnostics Working Group, chaired by Professor Chris Woods and deputized by Shelley from Cairo. Can I please have control of the slides?
Just tell him that you will run them.
Okay. So the working group is, at the moment, we are 16 members, and we span all continents. The majority are from Africa and Latin America, and we are still recruiting more members. We have members from different disciplines within the science and medicine strands. and we hold bi-weekly meetings. So the objectives of the group are to regularly update the list, prices, and availability of validated tests. The second one is review, adapt, endorse, and validate laboratory checklists and SOPs, including sample collection, handling, and analysis. So the working group is transversal. That means we discuss and provide information on validated diagnostic tools and relevant SOPs to different other working groups where need be. Next slide. So the group, in the early days of the group, we brainstormed on what should be our focus areas or our key priority questions, and we reached consensus on 5 questions. And this was in the early days. You will find that some of the questions were really trying to address the issues in the early days of COVID-19. So question number 1 is, what is the feasibility and performance of alternative samples, nasal, saliva, or pharyngeal, for self-administered collection? So at the beginning of COVID, different countries, different labs were using different samples to test COVID. And I think even today they still do. And there is need for systematic research to find out how sensitive, how accurate are these different sample types in the testing of COVID. So question number 2, what is the impact on serological tests performance of different disease backgrounds? So if someone has malaria or HIV or tuberculosis, how do these serological tests work for them? Could they be having some antibodies that cross-react with those antibodies against COVID? Question number 3, what is the role of antigen tests in different populations and settings? We now have antigen tests that have been rolled out, and you need to know what is the role of those tests, or where can they be placed? Triage or primary diagnosis, where exactly should they be placed? PCR testing results, or what they call psychothreshold, associated with infectivity. If someone has a lower CT or a higher CT, what does it mean? Does it mean that they can transmit the virus, or they can't transmit the virus? So that was the question we're trying to ask. Can we determine which PCR result is more related or associated to the risk of transmitting the disease to others? And question number 5, which I will focus on, what are the various approaches to setting up biobanks for COVID-19 samples? Next slide. So as a group, we've decided that we focus more on increased biorepository and sequencing capacity for low and middle income countries. The rationale is that biobanking question is central to the mandate of the work group. It's evident we will face another pandemic threat long after COVID-19 is gone. We are still battling with COVID-19, and so there will be more challenges that are coming along the way. So we need to work out how we preserve the samples and they're used for research. Next slide. So the objectives is to establish a network of sentinel biorepository sites in LMICs, to develop COVID-19 responsive biobanking training program for science in LMICs, and develop biobank collaborations between LMIC and high-income countries to promote capacity building for LMICs personnel. Second objective, we want to enhance sequencing capacity for LMICs laboratories and to support research in the effect of variants on COVID-19 diagnostics. Maybe I want to expand a little bit on this, that COVID is evolving so fast. The virus is forming new variants, and we don't know what the effect that one has on the current diagnostics, and how we can progressively detect the new variants and respond timely. So that's the kind of capacity that we would want to focus on in the situation with setting up biorepositories. Next slide, which should be maybe the end of my minute. And that's the approach that we want to take, establishing sentinel laboratory sites in Africa, Latin America, Asia, basically low-income countries, and work with them to establish biorepositories that can preserve systematically these samples that could be used now or in the future when funds become available. And then alongside that, we want to do research that can enable these countries to detect new variants in time and what effect these variants have on the current vaccination or the current vaccines that we have. The last slide, I think. Yeah, we shall be supporting the programs and we shall be proactive in reaching out for funders, for those that have not solicited funds, so that we can gain more research funding for the group and keep it active. I think I should end there, and if there are any more questions, I'll be happy to take them.
Thank you very much, Wilber. This is Patty Garcia. Sorry, sometimes technology doesn't work. I got disconnected suddenly. But so we have heard about the group that is working on virology, immunology, and diagnostics. And now we invite you all to send your questions through a Slido. Wilber, just to start, so it is so interesting and so important to have all the world, and especially low middle income countries, networking on this and with this idea to try to increase the capacities for sequencing and having biobanks. So is there also part of the plan to try to share, I mean, like an open space where everybody from the group, from the networking, could also share about the type of new variants that are appearing? I mean, there have been, I mean, this is something that is changing very frequently. So have you discussed about that, having like open ways in which, I mean, people could be seeing what is going on also?
Yeah, thank you very much for that question. And I think this is something we really want to do to make sure that there's rapid sharing of data that is emanating from sequencing the new variants that are appearing. And I think we can work with the data sharing working group in how to establish such a communal site. But it is also established culture within the genomics area whereby you're required to share. If you sequence something new, you're supposed to deposit it in a repository so that it can be accessed by others. So we have somewhere to start from in setting up something like that that can increase sharing of information on the variants that are appearing.
Excellent. So I invite the participants, if anybody would like to raise their hand or share their questions through Slido, it's open, please. This is a very important topic. Maybe, and remember that also you will have the chance at the end of the session to share with us what do you think are the strengths and how can we better collaborate so to make the work of the Clinical Research Coalition more meaningful. So Aman, go ahead. I see your hand raised. Oh, well, we have a question here from Alan Yusuf. Do you have a resource to build the lab to differentiate the new viral strains? And there is another question. What is the current status or progress in biobanking? Wilber.
Yes, thank you. Do we have resources to establish laboratories for sequencing? I think this is something that we want to pitch to the funders meeting to enable us access resources to build that capacity in the low and medium income countries to have such a laboratory capacity to do the to set up biorepositories and also do the sequencing. The current status, it's really variable, especially in LMICs. For example, if I look at Africa, South Africa has done much of the sequencing. I think they've been very good at doing the sequencing, and I think the country put in some money to make sure that the sequencing was done. Kenya has done some work. Uganda has been doing some work. but it hasn't been as fast as we see in the UK, the level of capacity that the UK has to kind of sequence almost every proportion of samples that are tested are sent out for sequencing. So its capacity is low, but that's what we want to enhance to make sure that they are able to do more, and also responding timely, because it normally takes time before a new variant is informed in the low and middle income countries.
Yeah, so Wilber, we have only 1 more minute, but there is another question. It's true, biobanking and sequencing needs heavy investment. And well, there are several coming. How would you go about Sentinel sites? And are there some initiatives mapping both sequencing biobanking capacities, but not sure it is really global. Are you well connected with those? Can the coalition help via its members? And this is a very interesting comment and question from Nathalie, because I don't think it's the time to say that something is too expensive. I think we really need to increase the capacity worldwide. Wilber.
Yes, I think you've really addressed the question for me. It's a need, and we need to invest all that we can to make sure that we meet this need. And the coalition, we can come together and see how we can reach out to different bodies that can fund this kind of work, and also working together with other working groups, because I heard what the clinical epidemiology working group is going to do. If they are to do some clinical trials, that could be linked to setting up a repository, in which case funding can come and has different strands or work packages that can address different aspects. Sentinel sites, the reason why we are thinking of Sentinel sites is because we cannot afford to do every laboratory in each country. Maybe we can say maybe one big lab per 3 countries, or one lab per country. That's what we are thinking of in order to afford the resources and also the coordination, because you can't empower every single lab in every country.
Thank you very much, Wilber. So there are ways we need to do the mapping, Sentinel sites, but the thing is that sequencing and increasing the capacities in low middle income countries is a must, and the coalition is willing, and one of the things that I think it's going to be doing well is to advocate for the funding. Thank you, Wilber. And we will go on our next group. So the next group that is going to be presenting is the ethics working group. The 2 presenters are Professor Cheryl MacPherson from Grenada and Professor Jantina de Rees from South Africa. So go ahead with the presentation. Thank you.
Yes, there I am. Sorry, I couldn't unmute myself for a second. Hello, everyone. Lovely to be here and wonderful to hear everything that's been going on in the coalition. So the ethics working group, if you can change the slides, please. The ethics working group, like the previous speaker, we have a thriving and very dynamic and engaged group of persons, really quite senior names, I think, in bioethics, if you are in that space. Who have connected together for the past year, every 3 or 4 weeks, engaging in all kinds of issues relating to the ethics of COVID-19 clinical research. Initially, we spent quite a bit of time developing our role and understanding our role, as well as developing terms of reference. And of course, as bioethicists, we spent quite a bit of time understanding accountability, as well as our roles and responsibilities, and making sure that we were not seen to be substituting ethics review. Next slide, please. Our initial work involved engaging with coalition members around 2 questions that came our way. The one focused on multiple ethics review and researchers' responsibility, and the second question focused on researchers' responsibilities in returning serology results. We spoke with researchers to understand better their particular challenge that they faced, and worked with the working group to develop recommendations for how researchers could proceed in thinking about those particular questions in their research design. When no further questions came our way, we then articulated a body of work that we could pursue and that we thought would be helpful to health researchers working on COVID-19. And that involved broadly articulating 3 questions. One really coming from that first question around multiple ethics review that came our way, where we conducted some work around multiple review recognition, ethics review equivalency over ethics review recognition. That might sound familiar to you because we presented that work in one of the coalition webinars. We managed to attract some money from the WHO to support a consultant, Dr. Vasiliki Rahimzadeh from Stanford University, who then developed a report which is now publicly available on possibilities for as well as obstacles to fostering mutual review recognition between ethics committees, both nationally and internationally. We then, based on our discussions internally around the ethical challenges that many of our members faced, many of our members are also members of ethics committees or national ethics councils, and that led to a funding proposal where we initiated the development of guidelines for ethics committees tasked with reviewing vaccine research proposals. So there was a concern at that point that many of the ethics committees in lower middle income countries did not have any expertise in reviewing research ethics proposals involving, or clinical trials involving vaccine research. And so we then worked to develop guidelines for ethics committees. And then a third project that we've been busy with is exploring the efficacy and the applicability of some Nuffield Compass, and the current co-chair of the ethics working group, Cheryl, will speak to that. Over to Cheryl, and next slide.
Hi, thanks, Jantina. So we had one of our working group members, Dr. Elise Nouvet, who did obtain some WHO funding in conjunction with the working group to do a consultation about the Nuffield Ethics Compass. And her consultation was in Guinea with really high-level researchers, research ethics committee members, institutional authorities and national authorities, and it was held over 2 days. So for those of you who aren't familiar with the ethical compass, I probably should just briefly state what that is. It was released by the Nuffield Council just over a year ago. It was created prior to COVID. And the idea is you're seeing it pictured on the right-hand side of the slide here. It's part of a larger document, but that's sort of the summary. So the 3 values or principles in the center: helping reduce suffering, fairness, and equal respect. And the idea is to use those to help reviewing if you're on a research ethics board, but also to help in setting policies if you're an institutional or other type of policy maker or leader. And also, if you're a researcher, to think about how best to accomplish your research in the best possible way.
1 minute.
So this consultation was held in Guinea, and what we're proposing, so next slide, the outcomes of the project in Guinea were that people there did find the compass really useful across all those different ranges of stakeholders to gain insight. And it also highlighted for them that what they were doing in terms of community engagement wasn't quite what accomplishing what they wanted it to. So that was a really useful, valuable experience for them. So we're proposing to do multi-country consultations similar to this, and we have countries already interested, or at least representatives who would be willing to facilitate it. We don't have funding yet, but that would be another step in making this happen. And they don't necessarily have to be 2 full days, but we'd like to try to run it comparable to what was done in Guinea. The idea here is that if we do this, one, we're building capacity and knowledge in those countries and among those key people. 2, we're actually meeting one of the needs, well, perhaps 2 of the needs mentioned by Helen Rees earlier this morning, in that we're creating a platform for discussion of issues around COVID and public health emergencies and ethics, and ethics review. And we're also creating the possibility for authorship from the host countries. And finally, if we find synergies, which we are likely to find between the challenges found in different countries, this will help us to advance appropriate responses or suggestions. So in our plans for moving forward, we're hoping to do that in multi-country consultations. We're going to remain available to those who want to ask us questions or consult us as a working group, as we did in our first 2, but there admittedly hasn't been a lot of interest, although I think those who did so found it very helpful, and we found it very interesting talking about those issues. And finally, we genuinely want to try to find time in everybody's busy schedule to actually reach out to some of the other working groups and perhaps sit in on some of your sessions or have you sit in on some of our meetings. Because if we do that, we can then begin perhaps to talk across disciplines in a more meaningful way. And listening to the talks this morning, I mean, I'm already fascinated by this idea of biobanking from the previous talk and how it cuts across all of our disciplines, all of the working groups' work. Really, it's an issue that has relevance, I think, to all of us. So as did several of the other talks, I think the data management is another interesting working group, and really all of them. So we just really want to encourage and make ourselves available to you and hope that we can start some conversations with you as we go forward. So thank you. That's all from us.
Thank you so much, Cheryl. And I would like to invite everybody to use Slido for the questions. Some people are posting questions on the chat, but that makes it a little bit difficult for the rest to see it. If you have difficulties, the other thing that you can do is you raise your hand. Also, I would like to point out that in the chat, Laila has been posting some interesting documents from the ethics group. You can click on it, and that will take you to the website. Actually, at the website of the coalition, there are very important and interesting documents from all of the different groups that are are there, so everybody can access. So it's one way of sharing it. So maybe while we start receiving some questions, Jantina and Sherry, one question for you both. So if there are other countries interested also on being part of this consultation, I guess since the consultations are going to be performed as webinars, probably, maybe those that are kind of like in the same region, like Latin America, you may consider to have couple of countries at least all together. I mean, if there are some countries or some groups that work in ethics in the countries that are interested, what should they be doing? I mean, how to contact you, or what is the plan to move along on this?
I would say please email myself or my co-chair Jennifer, who's was unable to join us this morning, and we will, because we haven't put anything in place as yet. We've just kind of decided that this is our aim for the coming year. And so we're really open to that. And as I mentioned, there are a number of us in different countries who have an interest. I particularly have an interest in Latin America and the Caribbean region, and many contacts, particularly in Mexico and across the English-speaking Caribbean. And we could do a regional rather than a national. I mean, that might actually be an interesting way to, those are things that we need to explore. So thank you. That's a really, really nice thing to ask.
Thank you. Okay, so we are starting to have questions. So what will be the role of ethics in a biobank?
So I guess I could speak to that. Jantine might also like to, but there is a rather small but coherent and visible literature in ethics about biobanking, because it raises many concerns, for example, about informed consent when you donate samples. The whole issue, and I think it was brought up in the data management talk earlier, the idea of how do you ensure that participants understand what their materials that they're donating are being used for or may be used for in the future, and how do you, and especially under public health emergency situations, how do you do that under those pressures? So that's just one example that comes to mind right away.
Thank you so much. And I invite you all to see the chat. Maureen has posted that if you would like to express interest in participating and or partnering for this ethics project, you are invited. You can just click where it says here and you have the information there. Well, thank you very much, Cheryl, Jantine, for this excellent presentation and for the work that you are doing. And since we are a little behind on time, let's go ahead. Let's invite the next group. So the next group will be talking about it's the clinical pharmacology working group. We have Dr. Colin Pillai, who is the chair of the working group. He works in South Africa, and he will be explaining us the kind of things that the group has been doing. Welcome, Colin. The floor is yours.
I think that Colin might not be back yet. He had to step out from this meeting to attend another meeting, so I promised to fill in for it.
Yeah, welcome, Joel. Sorry, I couldn't see that part in my screen. So, welcome, Joel, darling.
All right, thank you.
From Thailand, yeah.
Yes, exactly. So I'm not Colin, but my name is Joel Tarning, and I work at the Mahidol Oxford Tropical Research Unit. I'm also a professor of clinical pharmacology with the University of Oxford. So I will talk a little bit about the clinical pharmacology group. So if I next slide, which shows all the members here. So we're 10 members at the moment, but we're open to recruit and welcome new members. So if you have an interest in clinical pharmacology and want to work with us. Part of our group is also Professor Philippe Guerin and Professor Nick White, who's part of the steering committee. And we are a group of very similar but distinct expertise in the clinical pharmacology field from really all over the world. So next slide, please. So if you look back on the first year of work here, we believe that the clinical pharmacology work that we're doing is cross-cutting, looking at prevention, therapeutics, and then pre and post approval activities. The working group aimed to use our research activities and capabilities to educate, review, and support therapeutic interventions, and also advocate for multi-center clinical trials looking at the safety, efficacy, and effectiveness of different interventions in resource-limited settings. So since the reality is that we don't really have a good small molecule for the clinical development, There are conflicting evidence to support treatment guidelines. Many of the drugs that we have been working on is repurposing of medications. And the approach that we have taken is to advocate for data sharing and also to use both basic and advanced methodologies to look at, to inform the clinical pharmacology of these compounds. So we use, for example, case reports all the way through advanced mathematical modeling, so-called pharmacokinetics and pharmacodynamics modeling, or PKPD modeling. We also inform each other in the group about collaboration opportunities and try to work together on these collaboration opportunities. The activities so far that we've done is webinars. We have done on, for example, controlled human infection challenge studies, model-informed drug repurposing for COVID, and also steroids for COVID. Written a few opinion pieces on traditional medicine and COVID research, and also some guidance, practical guidance on ECGs and blood collection for pharmacokinetic COVID trials. And we can share maybe the link to these activities and outputs in the chat so that you all can have a look at it. So we're looking at the broad objectives and try to revise that for more specific objectives when we move forward. So if we can have the next slide, please. So for the next year, we want to really stand out for good science. And to do that, we're going to start by looking at guideline review. So that means global and national review of guidelines to ensure that robust evidence base, to avoid inconsistency, and also to provide a strong opinions about that we can use to inform strategies for the COVID-19 treatments in low resource settings. We want to assess drugs, of course. These drugs that are included in country-specific COVID-19 treatment algorithms, and also worldwide if there is any of those. We also want to provide comments on the WHO guidance, and we can talk more about that in the Q&A. Furthermore, we are aiming to do more education, so gather available resources, tools on clinical pharmacology and make them accessible through the coalition website and then advocate for their use. We want to discuss with healthcare professionals dealing with COVID-19 patients in resource-limited settings and try to provide adversary roles and query resolution. And we also want to, of course, contribute to the scientific literature with publications in our field. In terms of regulatory authorities, we like to actively reach out to and offer technical support in the field of clinical pharmacology to health authorities and regulatory bodies from resource-limited settings. So this interdisciplinary approach to research, we hope, is a complement to other coalition working group efforts, and we would like to identify researchers both internally and externally whose work can be strengthened by our pharmacology expertise and that we can work together with. So that was the last of our slides, and many of the group has joined for this webinar. So please ask questions, and we'll all help to answer that.
Thank you very much, Joel. This is a very, very interesting presentation and a group that is doing a fantastic job. While we start seeing the questions that should be coming through Slido, let me make a short comment. I mean, this is so interesting that you are thinking about reviewing guidelines around the world. One of the things that we have been seeing is that several times the guidelines have not been based on evidence, and we have seen the use and abuse of drugs that have not been really helpful for ivermectin and have been causing other type of problems, like, for example, antimicrobial resistance or the appearance of other bugs that we didn't have before. Mucor is one of those. So it will be so interesting and one of the other problems is, and this is kind of like the question that I have, is the issues of self-medication in the countries and how they relate with those guidelines that are not well based in evidence. I mean, are you going to consider that into the kind of things that you will be exploring? This has been a huge issue in Latin America. I'm sure that it also in India and probably in Africa. So are you going to explore the issues of self-medication also related also with these guidelines based on no evidence?
It's a very interesting point. We haven't talked much about exploring that, but this is definitely something that we can take on board and see what we can do with. And I agree with you. There's so much literature out there on different drugs to be used, and different guidelines states different things, and a lot of literature out which is not peer-reviewed, so it's very difficult to understand and know what really works. And so we aim at least to try to start looking at this in an objective way.
1 minute.
Anyone else from the group, please also comment if you want to.
Yeah, we have Dr. Claire raising the hand. Go ahead, Dr. Rupinder. Claire. You have to unmute yourself, I think. If the secretary can help us.
Yeah. Am I audible?
Yeah. Go ahead.
Am I audible now? Yeah.
Yes.
Hello.
Yes, you can talk.
Yeah. Yeah. So I'm Dr. Claire, and I'm a physician scientist, and I've been working on drugs for COVID, as well as I've done some case histories. I want to ask you that I have been treating 300 patients with 100% recovery, and that too severe patients. So how do I go about it? How do I, I've written case reports, and I was thinking of publishing them. And I have some cocktail of drugs which I have been using on patients, and they have had 100% recovery. So how do I, as a part of this forum, or do I publish it, or because this is a very, very big thing for India. We had a double variant, and the double variant was a MERS and SARS-CoV, and I have had done this earlier also with the single variants. Yeah.
Okay. Okay, Joel. Maybe because we have a little time, let me also there are a couple of questions. I hope that you can see this in the screen also. One, what about having a guiding document to help analyzing publications and guidelines and providing feedback? And so go ahead and maybe answer Dr. Claire. And
yeah, so for the first question from Dr. Claire, maybe I can ask some help from either Nick or Philippe that works a lot with evidence-based publications to comment on that.
Yeah. Yeah.
Okay, Nick White here. I think that if you have an uncontrolled observational series with excellent results, then certainly worth publishing. But as we know, once you have promising results, it's really important that randomized controlled trials are conducted. So these observational reports are valuable, but they are pointers. They should not be taken, in my opinion, as evidence to change practices and policies. They are guidance to the research community represented here to conduct larger and detailed trials. So I encourage you to publish, if you can, in a peer-reviewed journal so we can see them. Over.
Sure.
Thank you so much, Peter. I'm sorry.
Thank you.
Yeah, I'm sorry, Dr. Rupinder. I will ask you to mute yourself. The time is over. And but for all the people that are posting questions, the questions are going to be taken into consideration, and there will be more time to discuss, I hope, at the end, especially about the strengths and how to better collaborate between the different groups. Thank you so much, Joel.
Okay,
so,
thanks.
Thank you so much. So I'm sorry, but the time is really short. And now we are going to have the next group that has, the next group is working on substandard and falsified COVID vaccines, and talking about the supply and the market dynamics. So we will have 3 presenters that will be talking. I hope that they will stay on time because we're still a little behind. We'll have Paul Newton from the UK, Paul Lotai from Kenya, and Andrew Farlow, which it says here, Brazil, Germany, and the UK. So welcome, and the floor is yours.
Thank you very much. This is Andrew here. Can I have the next slide, please? Thank you very much. We're going to split our time with Paul Newton. So my and Paul Lotte's 3 or so minutes will of necessity focus on current and shortly forthcoming activity that we will seek people to work with, and problems and tasks from the coalition as inputs. And like many of you, we don't have much resources, so we've been trying to create a bit more human resource capacity by exploiting overlapping activity. One area is digital and AI tools in the shape of a new expert group on digital and AI applied to health, which we launched in April. This has about 40 members, a growing Global South contingency. We chaired it quite deliberately from the Global South with colleagues in Ghana and Pakistan. Oxford's overseas groups took part in the launch, as did the London School of Hygiene and Tropical Medicine, and we have members from Brazil, across Africa, Middle East, Asia, Southeast Asia. And we have representatives from the Botner and the Gates Foundation as members, and they're looking for good tools that they want to scale up. And we're also connecting that with the Robert Koch Institute in Berlin, which has a new institute for AI and public health. So our second meeting of interest to you today will be in partnership with this working group, and this will be digital and AI tools for tracking interventions in general and substandard and falsified COVID vaccines in particular, and also looking at issues to do with access to vaccines, issues such as spare dose redistribution, allocation of manufacturing capacity, and any failures that anybody in the group wants to suggest that might be solvable using some of these digital and AI top technologies. And if you want to join the meeting, please let me know. The next round of activity of that group will be in partnership with the WHO and a large consortium of global North and South groups it will be a hackathon, a global health digital tool and AI hackathon with about 10 grand challenges that will be presented and will be open for 2 months, and we will kick it off and close it with a symposium, and the winning projects will get pilot funding from the funders that will be announced at the start. So if you want to take part or suggest a challenge, let us know, and we're also happy to include others in the partnership, especially from the Global South groups. We're compiling a list of 10 problems as we speak, and these will be refined in the July meeting, and they will go out in September, October. We have deliberately put the COVID-19 stuff in July because we can't run a hackathon that produces results next February. The second this is taking a minute, is the German hub for pandemic and epidemic intelligence. And because of my role in Berlin, I'm interacting with Berlin and the WHO on this. The WHO is organising a meeting at the end of June on this. We're running a meeting in July with the WHO and with the Pandemic Lessons and Future Preparedness Global Health Strategy Group. And the WHO is seeking joint projects and trying to work out how to do this, whatever this is. And we're trying to work out how to link it to other things, including the new activities in the UK and indeed in Oxford. And I'll be blunt, don't share it outside the room, but the notion of the hub, in my view, is problematic. It really should be in the Global South. So there are big issues about data sharing, the impact of the research on the research ecosystem of the new hub, and who gets all the benefits. So one of our focuses is to make sure it is less northern European focused, more holistic, more interdisciplinary, and we definitely need to raise the voices of the Global South, and I'm prepared as part of my activities to fight for that. Finally, the last thing that I will talk about is just there's a little bit there of our human resources. We've got a research assistant, we've got a couple of Masters in Public Policy project people coming over the summer to work on projects on COVID-19 vaccines and SF products. And we've got a new batch, a completely new initiative we're calling the Global Health Future Leaders Programme. And we've recruited 4 paid interns stroke researchers onto that programme who will start in August for 6 months. And we're really trying to sort of make these things have a really strong global South ownership as well as a focus. So you can go on to the next slide, but I think I'll cut to Paul straight away.
Thank you very much, Andrew and Paul. Possible to have the next slide, please? Thank you. So thanks everybody very much for giving the opportunity to discussing what I fear is a neglected topic within COVID research, and that is the prevention, detection and response to substandard and falsified vaccines. Substandard are those that are poor quality resulting from errors in manufacture, or more commonly in this circumstance because of degradation in supply chain, and falsified, also known as counterfeit, because of a deliberate fraudulent production. Next slide, please. So what are the risks? So led by Helen Van Asch and Celine Kaye in our group, we've been issuing reports every month on the public domain issues with substandard or falsified COVID-19 medical products, and also separately for vaccines. They're available at the link there. For vaccines, there's been a dramatic increase over the last few months since December, with multiple warnings by WHO, Interpol, UNDC, etc. And Dr. Tedros mentioned this in one of his news briefings a few months ago. Next slide, please. Next slide, please. So this is a map of where the reports are in the public domain at the moment. There are more that are not in the public domain. As you can see, they're widespread. Next, please. So what are the risks? So clearly inequitable distribution is a risk. Errors in cold chain, especially for vaccines that need to be stored at very low temperatures. Diverted vaccines will risk degradation because of poor storage. There's examples of theft. As multiple manufacturing sites started up to produce vaccines in a great hurry, those risk substandard production. Adulterated vaccines due to fraud or due to errors in supply chains, in factories, sorry, could also be very damaging in terms of vaccine hesitancy and leave vulnerable communities unprotected. There have been recent examples in South Africa, Mexico and Poland. Next slide, please. So what should we do to reduce the risk? There's very little joined up stakeholder data sharing across the multiple stakeholders who should have concerns about this. There's no real, thank you, there's no real joined up global and national risk analysis. There are plans for barcode systems for vaccines, but some vaccines they're not issued with barcodes, and many countries do not have the infrastructure for doing that. And also, where are the reference lab? If country X is concerned about a vaccine within their territory, how do they get this analysed in due time? And also, one thing that we're working on is to try and evaluate devices for screening vaccines in supply chains. We have none at the moment, and hence we're flying blind. We also need much more work, I fear, on public engagement to reduce the risks in different communities when we do have severe substantially falsified vaccine outbreaks. Next slide, please. Thank you very much.
Thank you so much. So again, please use the Slido for questions. Don't use the chat. Try to send it through Slido. We know that it takes a little bit of time to write it up and to show it in the screen. If you would like also to raise your hand for questions, you are welcome for that. So thank you so much. So regarding the kind of work that you're doing, I have a question. Are you planning on working on a risk analysis tool that could help the countries to anticipate those risks and start acting on prevention strategies. I mean, we are already doing the vaccination, so this is a very much needed instrument. I haven't seen one, but I wonder if you have, or if you are working on one that could be shared and could be used by the countries.
Thank you. As far as I'm aware, that has not been done yet. We're discussing this with other stakeholders, but it will need, I think each country and region will differ in their risk assessment. It needs a tool for all countries to use. And I think WHO have a mandate for facilitating risk-based post-market surveillance. So we're discussing with them about how this could be done. But it's desperately important, as you mentioned. Thank you.
Yeah.
Over.
Andrew?
Can I add
1 minute?
We had a sort of a discussion about this the other day, and we said, the problem with this is that, to solve all of the components of this problem could take years and years and years. And if you look at what's happened with the vaccines, there was a diagram shown the other day of how long it took to develop vaccines, and the lengths of the time were on the diagram, and they get tiny, 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 tiny till COVID-19. And it's like we shrunk all the time horizons. We did everything to shrink all of the pathways to getting those vaccines. And we've not had that sort of same grand project to shrink all of the timelines of all of these other components of the solution. And so one of the things I think that we'd like to push for when we do this meeting in July is to sort of tackle it, but say, look, this has to be coordinated to be done relatively quickly with the same sort of vigor, gumption and resources as was the case with the vaccines.
Yeah, well, one thing is to try to have the tools and the instruments that we need for the work that we're doing right now, but also we have to consider that we will need them for the future, and at least if we can collect the lessons learned, and so we can be prepared for the next pandemic and not do the same type of mistakes. So one of the questions is, should this kind of work that you are doing right now, should it be included in national vaccine deployment plans? I guess, Abu, you're talking about the risk analysis tools, maybe? That's what you're talking about? I don't know, Andrew, Paul, would you like to answer?
Perhaps Paul, but yes. I mean,
Paul?
we've also got Paul Lotte on the call, who's very much engaged in, on the ground, delivering products. He might give you pros and cons of this if he's there.
Time is over. Sorry.
Yeah. So, Paul, I don't know if you want to say something very short.
Abdul, absolutely agree. I think it needs to involve the National Regulatory Authority or the other stakeholders involved in vaccine distribution, but I couldn't agree more.
Thank you so much. Well, thank you, Andrew. Thank you, Paul, and thank you all the participants in this section. It has been a very, very important and interesting discussion of what these different groups have been doing. And now I would like, and thank you for all the questions. We're keeping the questions, they're very important. Thank you to all the participants for keeping engaged. And I would like to hand over to Brenda Okware, who will be moderating of the next two sessions. Thank you so much.
Thanks, Patty. So we're going into one of the last sessions, which is the last session of presentations, and I'll dive right in. So our first speaker is Professor Marcus Schultz from Clinical Management Working Group. He's a professor of intensive care medicine with over 25 years of experience and has been a PI in numerous randomized clinical trials and observational studies looking at invasive ventilation. So he's going to speak to us on oxys crisis management and highlight some pragmatic solutions to this crisis. Over to you, Marcus.
Thank you, Brenda. I hope everyone can hear me, and thank you for the nice introduction and also the opportunity to be here today. It's a pleasure to report on behalf of the Clinical Management and Resource Limited Settings Working Group. And thank you again for the introduction. Can I have my next slide, please? As said, I'm reporting here on behalf of a Clinical Management Working Group. This group has been led or is being led by Dr. Ariel from Nepal and Dr. Kumar from India. And I'm myself from Amsterdam, the Netherlands, and also affiliated to Moru in Bangkok, Thailand. can have the next slide. I think this is what everybody knows or recognizes from the news outlets over the last 14, 15 months. We have a big problem, what we can call a local shortage or local shortages of medical oxygen. And this problem seems to be increasing, actually. First reports were from the center of Brazil, and even some hospitals in the US were having this problem. But later on, with second or third waves of patients, it became increasingly clear that many other countries are struggling with this challenge, including India and Nepal. And very recently, we received an emerging call from the Republic of Suriname, where there's a big problem with regard to shortages of medical oxygen. Could I have my next slide? And I think we should see this against the background of what I now tend to call naivety in handling a or the pandemic. And I would like to stress that I was and probably still am naive myself. At first, many of us, including myself, thought that the biggest challenge would be the shortage of ventilators. And you all have seen how some countries aggressively entered the ventilator market to gather as many ventilators as possible for their own country. Also, there have been these initiatives to produce rapid manufacturer ventilators, of which some even got emergency approval. I also worked on some of them, one successfully, two unsuccessfully, but actually none of these have been used in patients. And we have seen the initiatives of sending ventilators to low resource countries, but in the end, this was not the solution. In fact, it's a shortage of personnel taking care of those ventilators, despite what many ministers of health, including in my own country, are thinking. The real challenge, let me call it a problem from here, is a shortage of medical oxygen. Could I have my next slide? It's clear that the main reason for COVID patients to be hospitalized is the need for supplementary oxygen. Actually, it's the #1 reason for these patients to get into the hospital. And at times they need very high flows of oxygen. In well-resourced settings, usually there's piped oxygen, like in my hospital, with large tanks close or inside the hospital, and sometimes there are even oxygen gas plants nearby. Not in my hospital, but in other hospitals in the Netherlands, this is usually the case. Be aware, though, that even in the current situation, the flow through the pipe systems could be too low to serve the surge of patients in need for supplementary oxygen. In resource-limited settings, the situation is often completely different. Usually, oxygen is delivered in cylinders, and at times there is no piped oxygen system at all. And large tanks are usually absent, as do, of course, the oxygen plants, as we have just learned from the Republic of Suriname, but also several reports from other countries. There are oxygen concentrators that can be used at the bedside. These normally serve one or just a small group, up to 4 patients, but only if the needed oxygen flows allow. Usually these concentrators can produce a flow of up to 10 liters of oxygen, and in COVID patients it's not unusual to use more than 10 liters. And they are, I say, per patient. Could I have the next slide, please? So this is where we as a group stepped in. A couple of weeks ago, we tried to find rapid solutions for this growing problem. And I think we can classify the solutions into 3 layers of solutions. Solutions at a country level, at a hospital level, and at the bedside. And we focus mainly on what can happen or what we can do at the bedside. But first, at a country level or regional level, if you like, there are several solutions, but probably these take time to become effective. Probably will not be in time. Think here of creating plans, mandating large tanks near to each hospital, and investments in larger number of cylinders per region or country. This was not further discussed. At a hospital level, several steps can and maybe should be taken as well, with the same comment that these also will take time and will probably be there not in time. Think here of investing in pipe systems, sufficient numbers of cylinders in the hospital, and also investment in oxygen concentrators and fair use. For instance, there is by now a shortage of cylinders, and in Nepal, for instance, as I understood from some of my colleagues there are hardly any cylinders left due to hoarding, and even concentrators. These oxygen concentrators have disappeared from hospitals, stolen, taken home, or towards to other places or other hospitals, all very counterproductive.
1 minute.
We think there's so much to win at the bedside, and this is what we discussed extensively and what was press released very recently. Could I have my next slide? To summarize, we suggest to prioritize low flow above high flow devices in hospitals, to use correct oxygen interfaces, that is the one that best fits a patient's individual need, and this may change over time in an individual patient, for instance, to monitor oxygen saturation adequately, and to use lower targets for starting, reducing, and finalizing or stopping the supplemental oxygen for an individual patient, and to reduce leaks and wastage. There are two interventions that can be used at the bedside. One of them is, could I have my next slide, the awake proning in patients that are not receiving invasive ventilation. It's a bit beyond the purpose of this meeting how this works, but we know it's a very effective, safe, and easy to use way to reduce the need for oxygen in the individual patient, and as such it could spare a lot of oxygen, which can be used for other patients. And the second step is to prevent using these devices like high flow nasal oxygen. As an indication, high flow nasal oxygen easily uses up to 60 liters of oxygen, that is per minute, per patient, while the other devices, including NIV and invasive ventilation, can use up to 10 or 15 liters per minute. That's a real difference. So I would like to thank you for your attention. I would like to thank the group members for their input and their advices. And if we go to my last slide, I'm more than happy to take any of your questions. Thank you so much.
Thank you very much, Marcus. And I think this work once again shows the need for each of us within the coalition to constantly be flexible and try and meet the ever-changing priorities or needs or different phases that come with the pandemic. I know you'd love to take some questions, and there are probably questions already that people are thinking about, but in the interest of time, I'm going to ask us to move on to the next presenter, and then we shall have one Q&A session, if that's okay.
Of course. Sure.
All right. So the next presenter is Professor Philippe Guérin, who is the director of the Infectious Disease Data Observatory. He has worked in the field with MSF and has garnered research experience from his time with Wellcome Trust Research Unit in both Africa and Asia. So within the coalition, he's a member of the steering committee and also lends his expertise to two working groups, that is the data sharing working group and the clinical pharmacology working group. Welcome, Philippe.
Thank you, Brenda, and thank you to everyone for listening. Next slide. So you have heard of excess mortality, which was retained by the clinical epidemiology working group as a priority. Yet, after discussing the problem of excess mortality for about a year, we don't see much progress happening in that field, and I will explain what I mean by that. So the idea is here is to assemble and expand all cause of mortality surveillance monitoring system, focusing on less resilient health system, and to try to assemble data that will help policymakers and the response on the pandemic, but not only looking at the direct cause of death due to COVID, but also the indirect impact of the pandemic, to try to possibly reorient particular program to cope with a problem that could be identified. Now, you might have seen the press, WHO recently made announcement on excess mortality as well as IHME. What we are trying to do here is complementary to all this effort and not a duplication, by looking at, instead of the public data which are usually generated by the Ministry of Health, of looking at additional source of information and use a tailored and adapted methodology to extract data on excess mortality. And obviously, very much like all the other presentation, it requires a framework to share, analyze, and compare data, and it has to be equitable. And that's very much what we would like to propose. Next slide. And so why would we do that? Well, if we look at the world data on excess mortality, this is how it looks like. Actually, from we have been monitoring the situation for about a year. Things have improved. A year ago, there were about 40 countries which were releasing their data on excess mortality. We have more than double today, with 81 national data set being openly available to whoever wants to do research on that. However, the problem illustrated by this map is that there is almost no data from low and middle income countries, a few from as you can see, from Latin America, but with the exception of South Africa, Tunisia, and Egypt, no one in Africa, and very few as well in South Asia and Southeast Asia. Next slide. So what could we expect from that? Well, as I mentioned, WHO and other partners are trying to support countries to build a national registry to generate this kind of data. But we know that this is something that will take time, and many of these countries don't have a national registry which is functioning effectively. And what we believe is that there are alternative data that could be used to generate real-time or near to real-time information to estimate excess mortality. And this could be a bottom-up approach, in a sense that we could use the research community to identify, extract, and generate this information. The approach that we are proposing, acknowledging that there is not a single group that can coordinate all of that at the global level, would be a regional approach with 10 regional hubs, trying to work at the level of the region to assemble, harmonize the data, and try to provide information that will be useful. And we have made an estimate for funders of what it will cost to do this kind of effort. Next one. And obviously, this is very much in line with the spirit of the coalition. This is not led by any group in particular, but much more a coalition of expertise working together, involving the regions, involving LMICs, partners, and trying to develop a consortium that will be generating this kind of data. We had some preliminary discussion with the African CDC, which are very much welcoming access to this data. But the African CDC is also in the planning of supporting the countries to build their national registry. We think this is providing an interim solution while waiting that we will have a national Ministries of Health led information that could support and generate this kind of information, which to date, unfortunately, in many low-income countries do not exist. Thank you.
Thanks so much, Philippe. So again, in the interest of time, we can only take one question, one for the oxygen presentation, and hopefully, if we have time, one for Philippe as well. So I'll just read the question at the top. This is for you, Marcus, from Dr. Nicola. So she says, we need to look at questions of supply of critical goods ethics in a pandemic. Work with the commercial sector, the World Trade Organization, the WHO. The question just got removed from the slide. Yeah, but she's asking that the oxygen issue illustrates this, and she's wondering how the coalition can work on this. So the coalition working more on working with all these other key stakeholders involved in the supply of oxygen. I don't know if Marcus, you have a comment on that.
I think it's an excellent comment. What the working group has focused on is how to deal with the problem at the bedside. So for the local doctors, how to tackle this problem, or maybe I should say the local healthcare workers, because it's the nurses and doctors that are turning the flow of oxygen, right? So we asked them, and there's this initiative to talk with the local doctors and healthcare workers how we can help them to reduce wastage of oxygen and to come to a more rational use of oxygen. I'm not sure if there is a place for us to play a role in other discussions, like how should the global community deal with this problem. There is this initiative, for instance, from the Netherlands that we are now sending, as we speak, overnight, a big oxygen plant to the Republic of Suriname. But this is only a solution for a very short period of time, and I'm pretty sure that the problems will arise on other places as well. So again, we focus mainly on the local care and rational use of oxygen.
Thank you, Marcus. But again, this just reminds us that the issue of health is never just involving one party. At the end of the day, it is a multi-sectoral approach that needs to be used to address a single problem such as the oxygen crisis. So thank you. I don't know if there's any quick question for Philip. I do not see any, but what I will encourage members present to do is, first of all, have a look at the press release. The link has been posted in the chat. But secondly, if there are any specific questions related to excess mortality or any of these presentations, feel free to still post your questions and we shall follow up with you. Thank you very much. And once again, I apologize that I've had to cut you short because of time. But we do have an exciting session coming up next. So over to you once again, Nick.
Thanks very much, Brenda. You've been listening to a remarkably diverse and rich selection of some of the activities of the coalition. It's unusual, I think, in a meeting to have such a breadth of disciplines. So let's get back to those questions we asked you at the beginning. So if we could have the next slide and get ready with your Slido results, or sorry, Slido inputs. So I'd like, if you could, to just think of one word that describes what we should be doing more of. I think the next slide is beginning. Yes, here we go. So if you could just ping in the first reaction you have of things that we should be doing more of. It looks like the dominant theme, we haven't got many actually. Obviously the resurrection of Slido has only just happened, but it looks like collaboration is what we should really be emphasizing. I mean, that's very useful if that's clearly the dominant theme. Any last, let's give it another 20 seconds in case there's anybody else who wants to put any other alternative things. That's interesting. So advocacy and sharing, which we can bring along with collaboration, and communication training, money, and so forth. Okay, I mean, I think that's a useful message. Shall we now go to what we should be doing less of? Or it's becoming alive now. Less talking. Oh, shut up. Less trying to get money. Interesting. Most people would advocate trying to get more money. Perhaps less talking refers to less talking and more doing, because I have to say, one of the products of COVID has been an enormous amount of hot air. Any other offers for what we should be doing less of? Yeah, I have to say I agree with meetings. Well, talking is still way out in the lead. Less multilingual communication. Okay, I think we got the message. Less talk. I assume that means more do. Okay, shall we now go to the third question? And this one, if we could put that one on the screen, which really is, what should we be trying to achieve? Now, this is open, and so I invite you to put your hand up and tell us, if you wish. I don't see any hands.
There is one hand. There is one
hand. I'm going to try and say Naya Kamis Nassor and then Yurik Ranjit. So let's have Naya Kamis Nassor first. Over to you.
Hi, everybody. So I am from Tanzania. What I think you should actually do as a coalition, aim to achieve more, is collaboration, especially on a developing country like Tanzania. I see many of the research has been dealing with the developing country, but none of them has mentioned Tanzania. I don't know, maybe it's because most of the people are not from here. So I think that's something also you should do maybe for this upcoming year. Thank you.
Thank you. We said, do encourage your colleagues to join our coalition, and then we could have a louder voice from Tanzania. Let's hear from Yurik Ranjit.
So, Good afternoon, everybody. This is Yurik from Kathmandu. This is afternoon here, so that's why I said afternoon. You know, what I'd like to see more is more of a collaborative kind of work, whereby we have more work being done in LMIC countries, because what I see is, you know, I studied in the UK, but I work here full time in Kathmandu since the last 10 years. And what I see is that there's a sort of a bit of a gap, and I know that a lot of you are trying to achieve that, but it would really be nice to see more involvement of, you know, least developing countries like, you know, Nepal and so on. Thank you.
Thank you, Yurik. I mean, certainly that's what we want. And of course, it's not easy for busy healthcare workers, academics, researchers, and so on to participate. And often there are greater difficulties in lower resource settings. But what you wish is exactly what we wish too. We want to see greater participation, and we want a louder voice. We really want low resource setting representatives to say what they think is needed for their settings and for everybody else's settings, but that voice needs to be heard. I would say that one of the good things that's happened in the last few weeks is we have now got some candidates who will be representing the coalition and therefore low resource settings in the ACT-A accelerator, which is one of the main vehicles for the development of therapeutics and vaccines for COVID-19. I saw another hand. Is that Benno? Or did it go down?
Sorry, I had a second part. Am I allowed?
Sorry?
On my part. I had a second part of the question. Sorry, am I allowed?
Who is speaking now? I'm sorry, I can't say who you are. Is that Yurik?
Yes, this is Yurik. Okay. Yeah, I had a second part. I just wanted to give an example. Just give me 60 seconds only. The reason that I'm saying this is because, you know, there is so much of confusion here at this part of the world. Like, we have vaccines from India, we have vaccines from China, and now there's a vaccine which is going to come from, you know, Russia as well, probably. And meanwhile, I tried to raise this issue a couple of times. there's so much issue of substandard and falsified medicines that they found something like, thousands of liters of disinfectants which contained hand sanitizers, in fact, which contained methanol, which were very harmful. And there are issues of fake medicines. And the thing is, like, it's there in the news, and here everybody knows. You go to the market, you can easily find these counterfeit products or substandard products, but well, nothing is being done. And it's just like you're sitting on a something which is about to explode, like a disaster waiting to happen. We knew that there's going to be a second wave, but the government never took they never took it so seriously. So now what's happening is that every day we have, since past around 10 days, we have at least 100 deaths due to COVID, and it was like actually 200. Now it has decreased, and there's in fact suspicion from a lot of people that it's like the government has actually decreased the test rate, because they used to test 20,000 people, whereas now they're testing 12,000, and today they tested 16,000 only, or at least they produced data for that only. Thank you very much. I'm sorry for speaking second time, but I thought that the issue was very alarming, and so that's why I wanted to share it with you, because this is something which is happening, and this is something which we are living every day. Thank you.
Thank you. No, this is well taken. I'd like to ask now Professor Phaik, my colleague on the steering committee. Abul.
Thank you. Thank you very much, Nick, and very distinguished presenters. I do agree that our coalition is trying to solve the COVID-related problems of LMIC. But unfortunately, there are very few professionals in the LMIC to do research to solve their problem, not to speak during pandemic, but even in normal situation. I think this is a great challenge for collectively for all of us. And I do not have any answer, but more thinking is needed involving the ownership of the countries, that research is inseparable from service. Thank you.
Thank you. Thank you very much, Abul. Now have Beno Yakubu, or is it Yakubu Beno? I'm not sure which one it is.
Great. Good evening. I think I want to equally say on the opposite side that we have a lot of even professionals at LMIC, particularly in Africa, that are working on research, working on COVID-19 research. Again, the only thing that we lack is maybe sometimes is advocacy, and I think it's a collective responsibility that we need to maybe reach out to those professionals to join the coalition, because many things are happening in Africa. Again, to achieve much, I think in this coalition, we need to work more with the regional groups, because these regional groups have a lot of information to share to almost all the working groups members. So I think that will really give us that opportunity to get more information and share to the greater world. Thank you.
Thank you very much. I'd like to go on longer, but we'd have slightly overrun. So let's just have the next slide, which is to tell you about what's going to happen in the very near future, which is very important, a meeting with the funders. So could we have the next slide, please? Yeah, so this is a meeting on Thursday, the 17th of June. Put it in your calendars, and we're going to be presenting to funders some of the projects that have been developed. You've been hearing about them this evening, and your feedback on these, both during this meeting and any subsequent feedback in the survey that we'll send to you, will be very valuable. We really want to direct the funders to what you think are the important priorities. So we'll have a what's called a no strings attached opportunity, which might be rephrased as no holds barred discussion. This will be opened by Dr. Veronica von Messling. She's the Director General for Life Sciences in Germany, the government of Germany, and the co-chair will be Professor Charles Wisonge, who's the Glopidar Vice Chair. So that's coming soon, and that's an important opportunity. Can't guarantee that they will listen, but your views, your advice, thanks Leila, your views and your advice and your input are much valued. So now I'm going to invite another of my colleagues on the steering committee, Akhona Tshangela from the Africa Centers for Disease Control, to give some closing remarks. So over to you for the final word, Akhona.
Thank you very much, Prof. Nick White. A very warm thank you to all of our participants as well for taking the time to attend the first Coalition Members Assembly today. This does really signify our collective resolve to make an impactful contribution in COVID-19 research, and especially low resource settings, and to think about how we can work more effectively together as a coalition. As we have heard today, the call for prioritizing COVID-19 clinical research needs in low resource settings is as urgent now as it was when the coalition began. There's still a lot to be learned about the social, economic, and epidemiological impacts and characteristics of COVID-19. So the need for more research in our own countries, especially the African continent as a whole, remains critical. Although we are seeing important research being conducted in low and middle income countries, often funded domestically, just to say, we still need much more, including clinical trials to better understand the effects of new vaccines and therapies in our own populations. More than 1/3 of the coalition membership, which I'm proud to say, is comprised of researchers from the African region, which shows the solidarity from our African researchers that only global collaboration and coordination will enable us to end this pandemic, which is also clearly shared by our other researchers, clinicians, public health specialists, and health workers and institutions from our other regions, which is Asia, Latin America, and other regions who are also members of the coalition. My organization, the Africa CDC, is a proud member, and we are happy to see the efforts of the various working groups to further expand on our own and our partners' efforts to identify the priority research questions in COVID-19 globally. Now, looking back at the first year, this has been a challenging year for researchers. We have all had to juggle many hats. Even each one of us has been affected by pandemic in more ways than we can mention here today. And therefore, I thank you for your dedication and hard work with the coalition on top of your many other commitments. It is my hope, I must say, that the first year's achievements of the coalition highlighted today, priority research questions, your webinars, articles, projects on ethics and data sharing, and so much more, will not only help us to address some of our context-specific research challenges and gaps, but will also be part of a positive and sustainable legacy when this pandemic is behind us. We will have worked in vain if we have not contributed to greater research capacity and health infrastructure in our countries, created new research networks that will serve us in future, and as well as contributed to a permanent change in the global health system that is not always as global as we would hope. If we look at the example of the oxygen crisis, which has once again come into the limelight by the devastating situation in India as well as elsewhere, these kinds of oxygen shortages predate the pandemic in resource-limited settings and routinely put at risk the lives of severely ill infants, children, and elders, putting clinicians in an impossible position. So I salute the experts who came together recently to put together simple yet practical guidance for crisis oxygen management that can be used in the immediate term. And this shows how the coalition can use its expertise and voice to address specific urgent challenges. I also note this experts' insistence that such measures are for emergency situations only and cannot replace sustained oxygen systems. The discussions in the last session and feedback received on the coalition in the one-year review have highlighted a few important points. And collaboration has definitely been one of those that have been strongly highlighted. The collaboration is crucial, and also highlighting that working across the technical working groups is very important. We can do so much more together with our varied expertise and our commitment in common. We must have a voice at the table. I think also this just came out just now, the past 30 minutes. Researchers in low resource settings must be part of priority setting and decision making at the global level as early as possible to ensure our research ideas, strategies, and priorities are part of global plans from the start, in addition, leading efforts in our own settings. We can help to increase high-impact clinical research and capacity in our own countries, with the emerging multi-partner projects being proposed by the several working groups, following their efforts to identify the most pressing needs in their areas of expertise. And this case in point is the proposal on biobanking. A systematic approach to building biobanking and sequencing capacity in low and middle income countries is crucial. And this is a key priority for the Africa CDC, just to say, with us building the various networks within the African continent, working with WHO for building pathogen genomics. But not only now, it should not only be for now, but also for to enable global preparedness for future pandemics and epidemics. The coalition has a strong voice and could be using it even more to advocate for research needs. And the lack of equitable access to new tools in low and middle income countries. So the priority research areas identified and projects proposed are an excellent starting point, but we must remain agile to respond to the changing priorities in an evolving pandemic. Resources, both human and financial, are still needed to move these projects forward. So just in closing, low and middle income countries should not be left behind, either in research, self-determined research priorities, or in equitable access to proven interventions, including vaccines and other health innovations that have yet to be discovered. Let us continue in the spirit of the coalition by working together with our external partners, leveraging our networks and expertise, and using our collective voice to advocate for what is fair. Help us to make this coalition more effective by sharing your ideas with us. And thank you once again, and a huge congratulations to the Secretariat for organizing this first meeting. Now I'd like to give back the mic to our exceptional chair, Professor Nick White, for his last conclusions. Over to you, Nick.
Thanks so much, Akhona, for those wise words. Remarkably, we've finished on time. I would really like to echo your thanks to the Secretariat who put on this remarkable meeting, a huge amount of organisation. Thanks so much to all the speakers, and most of all, thanks to all of you who have listened. And I wish you a very good morning, afternoon, evening, or night.